Good morning, doctors. Today we are on the fourth day of reading Oxford Handbook of General Practice for MRCGP International AKT exam. I am Dr. Sesha. I'm a study partner for studying for the MRCGP International exam, AKT Part 1. So we are at the page number 2110. Let's study. Cardiac investigations, electrocardiogram or ECG. Graphic recording of electrical potentials generated by the heart. Most surgeries now have an ECG machine that interpret themselves and print out their findings. Analysis is easier, but it's still important to be able to understand the significance of abnormalities and check computer analysis in clinical context. Interpreting ECGs. Many mistakes in ECG interpretation are the errors of omission, so a system approach is best. Check the standardization. You have to check the calibration of the ECG and the technical features, including the lead placement and artifacts. Heart rate. Usual speed is 25 millimeters per second. Each big square represents zero point 0.2 seconds and each small square represents zero point zero 0.04 seconds. Heart rate, how do you calculate a heart rate? Heart rate is equal to 300 by RR interval in large squares. So the time in elapse, number of the time elapsed in between the two RR intervals. Rhythm, regular in or irregular. PR interval, normal if less than zero point 0.2 seconds. QRS interval, abnormal if more than 0.012 seconds. So as we have discussed this, if your QRS complex is wide, more than 3 squares or more than 0.012 seconds, then you have to think in terms of wide QRS complex. QT interval varies with rate. At 60 beat per minute, it's normal if 0.35 to 0.43 seconds. P waves, present or absent, and what is the shape? QRS voltages, the height of the QRS complexes. So, it's better described in page 212, but mean QRS electrical axis, the sum of all the ventricular forces during a ventricular depolarization. Normal axis is minus 30 to 1 plus 120 degrees. So, if more positive, then left axis deviation. Sorry, if more negative, then it's left axis deviation. And if it's more positive, then it is right axis deviation. Rule of thumb 1. The majority of QRS complexes are above the baseline, that is they are positive in leads 1 and 2. The axis is normal. Rule of thumb 2. The axis lies at 90 degrees to a QRS complex where the height above the baseline is equal to the height below the baseline. Precordial R wave progression. Abnormal Q waves. So in precordial leads, that is V1 to V6, there should be an R wave progression. That means the R wave should be small and then slowly by V6 it should be increasing in height. It should not be either increase and then decrease or any other pattern. It should be a progressive increase. Abnormal Q waves. If more than 25% of succeeding R wave and or more than 0.4 seconds wide, then it is abnormal Q waves. So many times you find a small Q wave in the ECG. So whether it is an abnormal Q wave or a normal Q wave, because Q waves are indicative of myocardial infarction. So why? So what we have to check? So you have to check whether the next R wave. So if the QRS complex is more than 25% of the amplitude of the next R wave, you can check that in the ECG depending upon the small square counting. So if there's more than 25%, then or whether it is more than 0.04 seconds wide. So 0.04 seconds is one small square. So if the QRS, if the Q wave is more than one small square wide, then it is a pathological Q wave. ST segments. Either there is an elevation or a depression or shape change. T waves. The height, inversion or shape. You have to check the height, its inversion and shape. U waves. This is a small rounded deflection less than 1 millimeter. So if you are thinking in terms of U wave, it is always less than 1 millimeter in height. Follows a T wave and usually has the same polarity. So if the T wave is positive, then the U wave will also be positive, and if the T wave is negative, then U wave will also be negative. It will not be like a T wave is positive and a U wave is negative, or vice versa. So they should have the same polarity. Then you can think in terms of a U wave. Brief guide to common changes in the table 9.4 on page 212. We will study in detail. 24 hours ambulatory ECG. So ECG monitoring equipment is worn for 24 hours. Continuous monitoring may detect intermittent arrhythmias or ischemias. So this 24 hours monitoring is called Holter monitoring. Cardiac MRI or magnetic resonance angiography, used as the first line investigation to assess the patient with chest pain for suspected ischemic heart disease. So increasingly used in secondary care to provide detailed structural information about the heart and rapid angiographic images. This is also one of the main investigations suggested by NICE. Echocardiogram. Heart ultrasound. Local referral procedures vary. Two-dimensional ultrasound produces a fan-shaped cross-sectional moving real-time image of the heart, maybe a transthoracic or a transesophageal, used to assess the valvular abnormalities and the prosthetic heart walls, aortic aneurysm or dissection, heart failure, pericardial effusion, masses within the heart, myocardial abnormalities like aneurysms or hypertrophy, and ischemic heart disease or congenital heart disease. M mode. Plotted on a This is M mode ultrasound. It is plotted on a scrolling screen. The stationary structures appear as straight lines according to the screen. Moving structures appear as undulating lines, usually displayed within an ECG trace to enable identification of phases of the cardiac cycle. Used to investigate the movement of individual structural elements, example the walls, the chamber walls. Doppler enables the flow across the walls and AST and BST to be quantified. Cardiac enzymes. The biochemical assay of molecules released when the heart is damaged is cardiac enzymes used in diagnosis of MI. Troponins T and troponin I are preferred markers and more sensitive or specific than CK, AST, or lactate dehydrogenase. Together with CK, earliest to increase after MI. CK, creatine kinase, increases in MI, muscle damage, example, prolonged running or seizures, after IM injection and with dermatomyositis due to statins. CKMB assay may also help to classify whether a cardiac event has occurred less than 48 hours previously. AST is second to increase. Lactate dehydrogenase is the last to increase. So first to increase are troponins T and I, next along with creatinine kinase, less than 48 hours. Troponins are immediate, and AST is the second to increase, and LDH is the last to increase. Cardiac catheterization. Refer via secondary care. Involves passing a catheter usually via the femoral or brachial artery to the heart, used to measure pressures within the heart and great vessels, assess the oxygen saturation via blood samples, perform coronary angiography. Contrast is injected into the coronary arteries to assess their anatomy or patency, perform an intravascular ultrasound, perform the other procedures, example, angioplasty, valvuloplasty, cardiac biopsy. Complications of cardiac angiogram is arrhythmia, MI, stroke, death, hemorrhage at the site of insertion, thromboembolism, trauma to the heart and vessels, and infection. Exercise ECG. ECG testing while patient undergoes a graded exercise on a treadmill or a bicycle. Mortality is 1 in 10,000, used for diagnosis of ischemic heart disease, although cardiac MRI is now the preferred test for the diagnosis of ischemic heart disease. See, this is a new change, okay? We are not doing TMT anymore now as a routine. NICE recommends cardiac MRI and some tests we will read later on. Along with in the past medicine, we have a different uh, flowchart nowadays. For the patients with ischemic heart disease, 75% of have a positive exercise test, false positive rate of 5%. The assessment of exercise tolerance, response to treatment, a prognostic indicator, assessment of exercise related arrhythmias. Contraindications to a TMT. See, there are some contraindications. When there is a recent MI, less than 7 days, unstable angina patients, electrolyte disturbance is there, aortic stenosis, severe heart failure, known left main coronary stem stenosis. Okay, the person who has a known coronary stenosis, he should not go for a treadmill test. LBBB may not be possible to interpret the trace in left bundle branch block. Radionucleotide imaging. Secondary care test involves IV administration of a gamma-emitting radionucleotide and a gamma camera monitoring. Radionucleotide angiography uses technetium-99 labeled RBCs to calculate the left ventricular ejection fraction and assess the ventricular action. So myocardial perfusion scintigraphy uses a thallium-201 injected via IV during an exercise testing to demonstrate areas of poorly perfused myocardium. So this is stress thallium test during an exercise testing done during a treadmill test to demonstrate areas of poorly perfused myocardium. Patient information. This is the brief guide to common ECG changes. For detailed analysis of ECGs, refer to a specialized textbook is what they say. So we have another small PDF which has an ECG abnormalities. We will discuss as whenever possible. We will upload a video regarding that. Common ECG abnormalities and their causes. ECG abnormality. Tachycardia. Rate is more than 100 beats per minute. It could be physiological tachycardia, whether there is atrial fibrillation, atrial flutter, supraventricular tachycardia, or a ventricular tachycardia. Uh, Bradycardia, rate less than 60 beats per minute. It is physiological. Drugs, example beta blockers and digoxin. These are negatively inotropic drug is digoxin. Heart block, 6 sinus syndrome. Heart block, 6 sinus syndrome. So these are the four reasons. One is physiological. It can be physiological. Drugs like beta blockers and digoxin. It could be a heart block which is causing a low heart rate and a 6 sinus syndrome. Irregular. Assess whether any pattern or not. So irregular pulse, if you find an irregular pulse, you have to check whether it is regularly irregular or irregularly irregular. If it is regularly irregular, that means there is a heart block which is transmitting regularly and not transmitting regularly. And if it's irregularly irregular, it is definitely atrial fibrillation. Atrial fibrillation has no pattern, so it is irregularly irregular. 6 sinus syndrome also has no pattern. Ventricular ectopics normally no pattern, and a heart block has a pattern. So if it is a heart block, second degree heart block is conducting few beats and not others, then you will have a regularly irregular pulse. Rest of the three, 6 sinus, ventricular ectopics, and atrial fibrillation will be irregularly irregular. PR interval, short PR interval, nodal rhythm. If the PR interval is short, it could be either a nodal rhythm or a Wolff-Parkinson-White syndrome. So this is one of the criteria for WPW syndrome. There will be a short PR interval. So normal PR interval is 0.2 seconds. So if it is less than 0.2 seconds, then it is short. Prolonged. 0.2 seconds is equivalent to one big square. Prolonged PR interval, that is more than one big square or more than 0.2 seconds. It could be a heart block, sick sinus syndrome, drugs, example beta blockers or digoxin. Left bundle branch block, LBBB. So this usually the QRS is more than 0.12 seconds wide. There's a wide QRS complex in left bundle branch block. Last peak is below the isoelectric line in V1. Last peak is below the isoelectric line in V1. IHD. So as far as left bundle branch block is concerned, we have a star. We'll see what the star means. And also I have learned a mnemonic which is William and Marrow. So for left bundle branch block, we see a W in V1 and an M in V6. So IHD, causes of left bundle branch block is mostly related to an myocardial infarction. So ischemic heart disease, either high BP, cardiomyopathies, aortic valve disease, SVT, supraventricular tachycardias. Artificial pacemakers may produce a similar QRS complex. Right bundle branch block. QRS is more than 2.12 seconds wide, so it is more than more than 3 small squares, and so again there is a wide QRS complex. So if there's a wide QRS complex, you can check either it could be LBBB or an RBBB. If you are finding M waves anywhere in the ECG, check in lines of LBBB or RBBB, and then you check where the M wave and W waves are located. So last peak is above the isoelectric line in V1. So this is marrow. So you find an M in the V1 and W in the V6. Maybe it may be normal right bundle branch block or congenital heart disease like ASD or a valvular heart disease and an IHD, ischemic heart disease, or pulmonary hypertension or during SVT. So mostly these are the related to the right ventricular problems, either congenital heart disease, right ventricular hypertrophy ASD, valvular heart diseases, ischemic heart disease, pulmonary hypertension leading to right ventricular hypertrophy. So incomplete bundle branch block. So QRS less than 0.12 seconds with abnormal shape QRS complex. As for right, so the QRS complex, the reasons for incomplete bundle branch block is same as for left and right bundle branch block. In any of these conditions, it could be complete block or it could be a partial block. Like left anterior fascicular block is one which I've heard. So QT interval abnormalities. There could be a prolonged QT interval or a shortened QT interval. So prolonged QT interval, when is the QT interval prolonged? One thing I remember yesterday I was reading azithromycin is one of the drugs. So potassium, decreased potassium, hypokalemia is a cause of prolonged QT interval. Drugs like TCAs, phenothiazines, amiodarone, and SAH or CVA. SAH is we'll get back to you what is SAH. CVA, so cerebrovascular accident or SAH. Hypothermia and genetic. So in hypothermia, you have a prolonged QT interval. There can be some genetic causes for prolonged QT also. Shortened QT interval. So this only two reasons for shortening of the QT interval is increased calcium and decrease and digoxin. Calcium and digoxin, these shorten the QT interval. Abnormal P waves. Increased P wave amplitude more than 2.5 millimeters. So P waves, normal P wave amplitude is 2.5 millimeters. So if it is in abnormal P waves, there's an increase in amplitude, that is tall peak T waves. So is found in right atrial overload conditions like in tricuspid stenosis or pulmonary hypertension or pulmonary stenosis. So this is related to the right side of the circulation. Wherever there is an overload on the right atrium which is pumping against pressure, or pumping against pressure like tricuspid stenosis, or further pressure like pulmonary hypertension, or further pressure like pulmonary stenosis, then we have a high amplitude P wave. Biphasic P wave in V1. So in a V1, if we have a biphasic P wave, like you have a up and a down portion also in the P wave, plus a broad P wave more than 0.12 seconds. So more than 0.12 seconds is more than 3 small squares. If your P wave is up and down and more than 3 small squares, and noted in V1, often notched P wave in less than one limb leads. So this is a left atrial abnormality. Mitral stenosis, left atrial abnormality like mitral stenosis, aortic stenosis, or conduction abnormalities. So now you have a left atrial problem, that is there is a overload on the left atrium, either due to a mitral stenosis or due to a further aortic stenosis, or if there is any conduction abnormalities. So then you have a biphasic P wave. So anything related to left atrial pathology is biphasic P wave. If tall P waves are there, then it is right atrial pathology. Right ventricular hypertrophy, RVH. Strain pattern, right ventricular hypertrophy. There is a strain pattern, that is ST depression and a T wave inversion in the leads V1 to V3. So this is an important thing to remember. Right ventricular strain patterns and left ventricular strain patterns we have to see. A strain pattern is ST depression and a T wave inversion in leads V1 to V3. A dominant QR wave in Win V1 with a narrow QRS complex. There's a dominant R wave in V1. So normally uh, there is a R wave progression. So in V1 there's a very tiny R wave, very tiny R wave, up R wave, and but in right ventricular hypertrophy there's a dominant R wave. That means there is a high amplitude R wave in V1 with narrow QRS complex. So pulmonary stenosis, causes of, what are the causes of right ventricular hypertrophy? So there is a right heart overload, right pumping overload. So further on there is either a stenosis like in pulmonary stenosis, or there's a mitral stenosis, there's a pulmonary hypertension, there's an ASD which is causing more flow into the right ventricle. Similar changes seen with inferior MI, T wave upright, but there is a T wave is upright, but there's a strain pattern, and WPW syndrome, right ventricular hypertrophy. Mm, So this one was a star we have seen near the left bundle branch block. No comment can be made about the ST segment or T wave if there is LBBB. So table 9.4, continued ECG abnormalities, left ventricular hypertrophy. So left ventricular hypertrophy, it also shows a strain pattern, but there's ST depression and a T wave inversion in leads B4 to V6. So what we have seen in is that if the strain pattern is found in V1 to V3, then it is right ventricular hypertrophy, and if the same strain pattern, that is ST depression, T wave inversion in V4 to V6, it is a left ventricular hypertrophy. Large voltages of the QRS complexes. So these are large voltage QRS complexes. A sum of S wave in V1 and R wave in V5 or V6 alone would be more than 35 millimeters. That means 35 millimeters is 35 small squares, that is 7 big squares. So what are the possible causes of left ventricular hypertrophy? It is systemic hypertension, BP, aortic stenosis, anything beyond your left ventricle in the onward circulation. So Either there is high BP, your left ventricle has to pump against the high systemic blood pressure, aortic stenosis, coarctation of the aorta, or a HOCM. Right axis deviation. HOCM is hypertrophic obstructive cardiomyopathy. Right axis deviation. So we have seen briefly about right axis deviation and left axis deviation in the previous page. So let us see the causes. So what have we read about right axis deviation? What is the normal axis is minus 32 plus 120 degrees. So if your axis is predominant rule of thumb 1 and rule of thumb 2. So rule of thumb 1 in lead 1 and lead 2, if most of the QRS complexes are above the baseline, then it is right axis deviation, left axis deviation. Oh, where did it go? 210. Sorry, I forgot again, so we will read again. Yes, so rule of thumb 1. If majority of the QRS complexes is above the baseline, positive in leads 1 and 2, it is the axis is normal. It's a normal axis. And rule of thumb 2. The axis lies at 90 degrees to a QRS complex where the height above the baseline is equal to the height below the baseline. So we'll go back to our table. Sorry for the diversion, but we have to remember this for the exam. So right axis deviation. The causes of right axis deviation are right ventricular hypertrophy or strain following a pulmonary embolism, cor pulmonare, pulmonary stenosis, alone with normal QRS is equal to left posterior hemiblock. So if you will only have a right axis deviation along with a normal QRS complex, then it is left posterior hemifascicular block. Left axis deviation. So again, left axis, when is the axis deviated to the left side? When there is left ventricular hypertrophy and or a strain. Example, there is high BP, aortic stenosis, HOCM. So all the conditions for left ventricular hypertrophy. And then when there is a VSD or ASD, if occurs alone, so VSD or ASD again, what happens is there is left ventricular hypertrophy. If occurs alone with normal QRS, then left anterior hemiblock. So if the QRS complex is fine, normal, and still you are having a left axis deviation, then it is left anterior fascicular block or hemiblock. And if right axis deviation occurs along with normal QRS, it's left posterior hemiblock. Poor R wave progression. So R wave progression, we have said from V1 to V6, the R wave should increase slowly, 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 slowly. But if there is poor progression, that is the R wave is not increasing in size. Absence of normal, sorry, absence of the normal increase in size of the R wave in the precordial leads from V1 to V6. Old anterior MI, lead misplacement, common in obese women. It could be a left bundle branch block or left anterior fascicular block or a left ventricular hypertrophy. WPW syndrome, dextrocardia, tension pneumothorax with mediastinal shift, and congenital heart disease. So this is one thing which is peculiar. That is, in case of a tension pneumothorax with a mediastinal shift, you will have a poor airway progression too. Whether if you have a congenital heart disease, definitely. In WPW syndrome, you have a prolonged QT interval and a poor airway progression. Dextrocardia, old anterior MI, lead misplacements like in obese women, and left anterior fascicular block or LBBB. Abnormal Q waves. More than 25% Yes, we just discussed what was an abnormal Q wave. That is, if the height of the Q wave is more than 25% of the next R wave, that succeeding R wave, or if it's more than 0.04 seconds wide, that is more than one small block wide. If it's abnormal Q waves are normal, it could be a normal variant, or it could be left pneumothorax, dextrocardia, MI, myocarditis, hyperkalemia, cardiomyopathy, amyloid, sarcoid, scleroderma, LVH, left ventricular hypertrophy, right ventricular hypertrophy, LBBP, WPW syndrome. So you have an abnormal Q wave in all of these conditions, which is left pneumothorax, dextrocardia, MI. MI is an important condition. Myocarditis can have a small Q wave, hyperkalemia, cardiomyopathies, all these amyloid, sarcoid, and scleroderma, left ventricular hypertrophy, right ventricular hypertrophy, LBBB, and WPW syndrome. Okay, so when we discuss this particular syndromes, at that time we will remember more. ST elevation. So ST segment is raised more than 1 millimeter above the baseline. So this, what is an elevated ST segment? That is, it should be at least more than 1 millimeter above the baseline. So more than 2.5 small squares above the baseline. And the causes are MI, Prince metal angina, pericarditis, ventricular aneurysm. ST depression. When do you see an ST depression? What's an ST depression? ST segment is lowered more than 0.5 millimeters below the baseline. So 1 millimeter is 1 millimeter is one small square, and 0.5 millimeters is half of the small square. So angina. ST depression, the causes could be angina, ventricular strain. Yes, we have seen, right? Strain pattern, ventricular strain pattern, right ventricular, left ventricular strain pattern. So in that there is an ST depression. Could be due to drugs like digoxin and verapamil, hyperkalemia, myocarditis, cardiomyopathy, fibrosis, and Lyme's disease. So this is one thing. In Lyme's disease, you have pericarditis, myocarditis, and there is also ST depression in the ECG. Cardiomyopathy, fibrosis, and digoxin and verapamil. ST depression. T-wave inversions. Where do you see in a T-wave inversions? Is abnormal. So normally there can be normal T-wave inversions. So T-wave inversions are abnormal if inverted in leads 1, lead 1, lead 2, or V4 to V6. That is left-sided leads, V4 to V6, or 1 and 2, lead 1 and lead 2. Only in these leads, if there is T-wave inversions, it's abnormal. MI. Inverts less than 24 hours after an MI. Ventricular strain. We have seen ventricular strain, the causes of ventricular strain that can lead to a T-wave inversion, ST depression and T-wave inversion in right and left ventricular strains. Whereas in right ventricular strain, the V-wave inversions will be in V1 to V3, and left ventricular strain, the T-wave inversions will be in V4 to V6. Pulmonary embolism, in lead 3, you have a T-wave inversion. So digoxin, pulmonary embolism has a specific ECG abnormality. Once we discuss that, we will discuss digoxin, or once we discuss an ECG, we will discuss digoxin. V5 to V6, there is a T wave inversion. U waves, increased amplitude more than 1 millimeters. Drugs like quinidine, procainamide, and D-isopyramide. These are the class 1 antiarrhythmics. Or reduced potassium, that is hypokalemia. So drugs and hypokalemia cause U waves. Inversion in the precordial leads. Subtle signs of ischemia. Prevention of cardiovascular disease. 1 in 3 deaths result from heart disease. In England alone, there are near about 32,000 stroke related deaths each year in England. Risk factors for cardiovascular disease is listed in table 9.5. We will check that. Primary prevention aims to stop cardiovascular disease developing. Population strategy influence factors that increase the cardiovascular disease CHD risk in an entire population like primary prevention for CHD is anti-smoking campaigns. The GPs can do this by displaying health education posters or literature in the waiting room or in the practice leaflet. Health checks for over 40 years age. This is a national screening program for people aged 40 to 74 in the UK to identify CBD, DM and cancer earlier through health checks every 5 years. The check provides lifestyle advice, information about cancer screening programs available in the UK, the CBD risk assessment including demographic information, family history, smoking status, alcohol consumption, BMI, BP and lipid profile. So they do a CBD risk assessment including while they take history and they check the smoking and alcohol status and BMI, blood pressure, lipid profile and DM risk stratification. We can see in 315 page. High risk strategy. So once you assess if they are at high risk, then what is your strategy? So CBD most of the CBD occurs in individuals of medium risk as that is largest group. However, individuals at high risk have the most to gain from the risk reduction. This strategy aims to identify individuals at high risk through opportunistic screening and health checks and decrease their risk through lifestyle modification plus medication. High risk groups. Who are the high risk groups for CBD risk? All the people aged more than 85 years, all patients with a familial dyslipidemia, people with EGFR less than 60 ml per minute per 1.73 meter square or an albuminuria, people with type 1 diabetes who are more than 40 years of age or have had diabetes for more than 10 years or have established nephropathy or other CVD risk factors, people with 10 years CVD risk of more than 10% using the QRISK 3 calculator. So these are the high risk groups according to CVD risk. Current risk estimation tools give 10 years CVD risk. The Joint British Society tool provides the estimate of lifetime risk. This is particularly useful when discussing CVD risk with younger patients, like the 10-year risk is often low regardless of the risk factors. So when the patient is younger, you use a lifetime risk tool by the British Society. Factors used in the QRISK-3 cardiovascular risk calculation. It is available online, you know. You can check this QRISK-3 cardiovascular risk calculation tool online, and once you enter for one patient or for yourself, you will know what are the factors involved, what you are entering. One is age, gender, you enter the ethnicity, you enter the socioeconomic status, you enter the BMI, you enter the cholesterol level, smoking history, diabetes, family history or of cardiovascular disease, atrial fibrillation, blood pressure medication you're taking, CKD, rheumatoid arthritis. See, these are two connective tissue disorders also are there. Rheumatoid arthritis, SLE, and severe mental illness, antipsychotic medication, and steroid medication. So once you enter for 3 or 4 patients in your clinic, you will remember all these criteria very well. What you are entering is what are the factors that are used for QRISK calculation. Calculate for your family members, and you will remember these factors. If the risk score is near the threshold for intervention, consider other factors that may predispose to CBD and cause risk underestimation. Has the person recently stopped smoking? Is the patient, so if 10% is the risk score, right? So you have a 10% uh, risk of getting a CBD in the next 10 years. If your QRISK score is 10, then you will start some intervention. So you'll start statins, etc. So once your risk is at 9.5 or risk is at 9, then you should not say no, it is 9. When it goes to 10, then I will start the intervention. At that point you have to find out whether he has just recently stopped smoking. So right now you have entered his smoking status is negative. See where here smoking status is negative, but did he recently stop smoking? Is the patient already taking lipid lowering therapy? So that's why his so there are other two things you enter. One is non-HDL cholesterol and the HDL cholesterol levels. So if there is other he's already taking lipid lowering therapy, that's why his lipid levels are normal. Does the patient have a raised triglycerides? Are the other conditions present? That is increased risk conditions like psoriasis, HIV, other systemic inflammatory disorders, taking immunosuppressant medication. So these are all which you have to keep in mind before starting or not starting a statin. Secondary prevention aims to stop progression of symptomatic cardiovascular disease. 46% people who die from MI are already known to have a cardio congestion coronary heart disease. There is strong evidence that targeting patients with CVD for risk factor modification is effective in decreasing risk of recurrent CVD. So that is why you have to go for secondary prevention. Risk factors for cardiovascular disease. This was one table which we said we will discuss. Non-modifiable. So what are the non-modifiable risk factors? Means you can do nothing about them. Like the age of the patient, you can't change the age. The sex of the patient, males are more predisposed than to females. They are born males or females. You can't change that. That's why it's non-modifiable. Less than 65 years. Sex in those less than 65. So in uh, males are more predisposed less than 65 years. Younger males are more predisposed than women. Ethnic origin. In people in the UK, people who do not originate from who originate from Indian subcontinent have higher risk. Afro-Caribbeans have lower risk. Socioeconomic position. Personal CVD history of CVD. Family history of CVD. Less than 50 in 55 years in males and less than 65 years in females. So this family history, you cannot say that a 70 years old person, his parent has died of CVD, that's why he's risk. No, family history is significant when the person, a male family member has died less than or had CVD less than 55 years age, and a female family member has had CVD less than 65 years of age. Low birth weight IUGR. Low birth weight baby is at risk for CVD. These are non-modifiable risk factors for heart disease. Modifiable or proven benefit. So modifiable factors, if you modify them, there's a proven benefit towards decreasing the risk for heart disease like smoking, hyperlipidemia, hypertension, diabetes, diet, obesity, particularly waist hip ratio, physical inactivity, alcohol consumption, left ventricular dysfunction, heart failure, secondary prevention for heart failure, coronary prone behavior, competitiveness, aggression, and feeling under time pressure. Secondary prevention, behavior modification is associated with decrease in risk. So these are all the modifiable factors where you can do something and it will improve the um, chances that decrease the chances that the person will not have a heart disease in the next 10 years. Modifiable unproven benefits. So still the benefit is not proven, like hemostatic factors like increased plasma fibrinogen, apolipoproteins like lipoprotein A, increased lipoprotein A, homocysteine levels, increased homocysteine levels, vitamin levels, decreased blood folate, vitamins B12 and B6, and depression. So these are modifiable factors that cause heart disease, but there's no benefit to treat them. The GP's role. GP have a role in identification of patients who would benefit from primary prevention, ensuring patients at high risk of atherosclerotic disease having ongoing follow-up through disease registers, routine recall and follow-up, promoting lifestyle modification in at-risk patients, ensuring current best care guidelines are followed and treatment regimens are updated as policies change. This is a major challenge for primary care guidelines as the guidelines change frequently and often conflict. Checking the process through audit. Yes, this is actually very important because every year you have a different guideline for blood pressure control. So every year you have a GNC criteria. So the guidelines change so frequently that today if you have convinced the patient that your blood pressure is okay 140 by 90 at some age and it's okay, it's normal, tomorrow the guideline will change and then you have to say a completely different thing to the patient. So checking the progress through audit is the next one. Blood pressure measurement. Taking a blood pressure. Use a validated sphygmomanometer. A list is available on the British Hypertension Society. Regularly maintain and calibrate your sphygmomanometer. Use a cuff or correct bladder size. That is, most adults 12 into 26 centimeters cuff, large adults arm circumference more than 33 centimeters, 12 into 40 centimeters, and thin adults and children with arm circumference less than 26 centimeters, 10 into 18 centimeters cuff. Seat the patient comfortably with the arm outstretched and supported at the level of the heart. Measure the BP to the nearest 2 millimeters Hg. Measure the diastolic BP when heart sounds completely disappear. Only use the pressure at which they suddenly muffle when K5 cannot be determined. Measure blood pressure in both the arms. If the difference between the systolic BP is more than 10 millimeters of Hg between both the arms, repeat the measurement. A consistent difference of more than 10 millimeters of Hg is an independent risk factor for CVD and all-cause mortality. Treat identified CVD risk factors. Use the higher of the two readings when considering further management of BP. So you have to use the higher of the two BPs in both the arms, not the lower one, for considering management. Automated devices may not measure BP accurately if there is a pulse irregularity, that is atrial fibrillation. Check the radial or brachial pulse before checking the BP and measure BP manually using a direct auscultation over the brachial artery if the pulse is irregular. So you have to check the pulse of the patient first before checking the BP. If the pulse is irregular, you're not getting a good BP recording from an automated machine. White coat hypertension. Prevalence is 10%. Some patients BP increases in response to having the BP checked. So if the BP is more than 140 by 90 in the consultation, take a second measurement. If the measurement is substantially different from the first measurement, take a third measurement. Record the lower of these measurements as the BP. So you have to take 3 measurements and record the lowest one. If the BP on repeat testing is more than 140 by 90 millimeters of Hg and not known to be hypertensive, offer ambulatory blood pressure monitoring. Yes. So you have two criteria and nice. One is ambulatory blood pressure monitoring, home blood pressure monitoring, and clinic blood pressure monitoring. And they have given different criteria for hypertension depending on whether it is an ambulatory monitoring or a clinic monitoring. Home BP monitoring you have to, so if the BP on repeat testing is more than 140 by 90 and not known to be hypertensive, so offer an ambulatory blood pressure monitoring or home blood pressure monitoring to confirm the diagnosis. Consider ABPM or home BP monitoring HBPM for people on antihypertensive medications who are known to have white coat hypertension. If hypertension is not confirmed on ABPM or HBPM, measure BP every 5 years and more frequently if close to 140 by 90. If the person has severe hypertension, systolic more than 180 or diastolic more than 110, consider starting antihypertensive medicine immediately without waiting for the result of HBPM or ABPM. Refer for same day specialist assessment if suspected only if there is an accelerated hypertension. BP more than 180 by 110 plus papilledema plus retinal hemorrhages. So accelerated hypertension is there. Pheochromocytoma, labile or postural hypertension, headache, palpitations, pallor and excessive sweating along with a high BP. So you have to think in lines of pheochromocytoma and refer immediately same day specialist assessment. Ambulatory blood pressure monitoring ABPM. A BP measuring device is worn on the body for 24 hours. It takes BP every 20 minutes in the daytime, 20 minutes and in the daytime, and less frequently during the nighttime. Increased BP readings on ABPM are more strongly correlated to end organ damage than one-off measurements, and ABPM is used for diagnosis of hypertension. Diagnosis of ABPM is used for diagnosis or exclusion of white coat hypertension, monitoring of responses to treatment, and assessing medication related postural hypertension. So, interpretation ABPM is considered abnormal if average daytime measurement ABPM is more than 135 by 85. Average nighttime measurement is more than 120 by 70. So we have some questions in the past medicine which has this concept tested. So let us be confident about this. NICE bases the diagnosis of hypertension on average daytime measurement only. Only on the daytime measurement. So when you have a question stating nighttime BP is high 135, more than 135 by 85, then it doesn't matter. But if the morning daytime average is beyond 135 by 85, then it is hypertension. Nighttime ABPM. Night BP falls at night in normotensive individuals. Some hypertensive patients are described non-dippers. So normally a BP falls at night time in normotensive individuals. So some hypertensive patients are described as non-dippers. So there is no nighttime drop in BP. This means that the BP does not fall at night and is associated with increased risk of target organ damage. Conversely, some hypertensive patients have excessive dips in the night, more than 10%. This is associated with increased CVD risk. So this is the significance of nighttime ABPM. Okay, so we are done for today's class. We are at page number 217. We will continue from page number 217 tomorrow again. Thank you.